Lorenza Rimassa, the second Umberto Cillo. Basically, I tried to put them a question. I don't know whether they will answer my question. I don't even know whether it's a proper question. And it is how doctors look at patient associations. So the idea is, how can we improve the relation with doctors? We know that doctors are, for us, very, very important. In a way, my political line is have a good relation with doctors, but the association has not to have doctors in, not at least in the committees, because otherwise it becomes the association of the doctor, the two doctors in the committee, and this is bad for a national-wide association. Lorenza Rimassa from Humanitas, Milan.
Thank you, Paolo. Good afternoon to you all. I'm really happy to be here today with you. And I'm really happy that most of the things that I put in my slides have already been presented. So at least we know that, we are on the same page, and this is the most important thing to me, at least. Paolo, I'm sorry, but can you go next slide, please? So I'm a medical oncologist. These are my disclosures. This can be bad or good, but I think this is important because if we have relationship with the industry, we can use drugs and we can participate in clinical trials for our patients. And next slide. So this is my agenda. I will start from what we had and what we need. To me, the role of the patient associations and how we can best collaborate, because I think that the collaboration between patient associations and physicians who are involved in the cholangiocarcinoma, in treating patients with cholangiocarcinoma, is key for better outcomes. Next slide, please. Where we are. This is the treatment algorithm from the ESMO guideline, the most recently published. We have different options. Of course, we can and we have to do better, but at least we have more options than a few years ago. We start from surgery, but focusing on systemic therapy, we have now chemoimmunotherapy in the first line and targeted agents in the following lines based on the molecular profiling. Next slide, please. But of course, there are several challenges that we still have in the possibility to administer treatments. For instance, we don't have the possibility to administer targeted agents in first line. So also patients with actionable alterations have to receive chemoimmunotherapy and then targeted agents. But now there are ongoing trials testing targeted agents in first line. Targeted agents are available in the following lines for patients with actionable alterations, but for few of them. For most of the alterations, we don't have yet, hopefully, targeted agents available on the market for clinical practice. But again, this is, I think the hope for the future is that now we have clinical trials now, for instance, even testing targeted agents in a sequence. So we have clinical trials for third-line treatment with targeted agents. This is something that was not even imaginable, thinkable a few years ago. Other challenges are represented by the limited access to immunotherapy. We are now here Europeans, but if you think of people living outside the let's call Western countries, immunotherapy is not available for most of them. Targeted agents are not available for most of them, so we have only, those patients have only chemotherapy if they have chemotherapy. In clinical trials, I'm happy that we have several clinical trials from the adjuvant or neoadjuvant setting to the advanced setting, but you all know that in clinical trials, only patients who are in very well clinical conditions with perfect lab test, with all the different eligibility criteria, only those patients can be included. And we do need, and now there are some trials including also patients with let's say, not perfect baseline characteristics. And so we are, also the industry now is probably the different pharma companies are starting to think of including more diverse population in clinical trials. And for instance, for the chemoimmunotherapy now, there is an ongoing trial that is including patients the patients that were excluded from the phase 3 trials. So maybe in the future we will be able to offer chemoimmunotherapy also to a broader patient population. And also on the same line, we now can offer in first-line chemoimmunotherapy with the cisplatin and gemcitabine, but some patients cannot receive cisplatin, for instance, for kidney diseases, renal dysfunction, and so on. And again, there are trials now testing immunotherapy with different chemotherapy regimens, maybe a less toxic chemotherapy regimen. So maybe in the future we will have more options, and also we will have the possibility to treat more patients with the options that now we have. And the next slide, please. And this, I'm happy, Elizabeth already mentioned this, the Lancet Regional Health Europe, that is one of the Lancet journals, approached me couple of years ago, or 3 years ago, with a project on biliary tract cancer in Europe. And in the end, we were able to publish on the Cholangiocarcinoma Day 2025, 2 papers, one comment from the patient associations, AMF, APIC, and A2VB, and one comment that the Lancet group usually ask the reviewers of the papers to write. So in the end, on that day, we had 2 papers written by the physicians involved in biliary tract cancer or cholangiocarcinoma in Europe, and 2 comments, one from the patient associations. And there was the possibility to identify some of the priority areas for actionable changes you can see in the slide. And starting from awareness, we are all working to improve the awareness of cholangiocarcinoma, but we still to do more. Identifying biomarkers, because we don't have so many biomarkers. Addressing inequalities, as mentioned, not all the patients have the same possibilities in different countries and in the same country. We have to improve the multidisciplinary teams that should be focused on cholangio and not in general on cancer or on GI cancers. And of course, improving collecting data. As Helen mentioned, we still think, or actually most of the people still think, that the most frequent liver cancer is HCC, but now we have data from the UK that is more or less 50-50. So we need to improve and to improve in different areas. And one of the idea of the idea of this Lancet group work initiative was try to identify also priority areas for actionable changes. Next slide, please. And the aim is always to put the patient first, because we are physicians, we have the industry, we have the research groups, we have the politics, we have the patient associations, but the aim is to improve the survival and the quality of life of the patients. And you can see on the right in the slide that now we know that quality of life is associated with survival, so we cannot think only of new drugs or new options, but we have to think of maintaining the quality of life of the patients. And of course, in some way, I don't know if the quality of life is the correct way of saying that, but the quality of life is not only of the patients, but the relatives, the families, and all the people around the patients in this disease. So next slide, please. And so coming to the patient associations, and this has already mentioned today, which are to me the role of the patient association, and how can patient association help the patients and their families and loved ones and work together with us. And to me, it's offering educational, emotional support and resourcing, and I'm happy that this morning we have already mentioned this, especially the emotional support that we unfortunately cannot provide, or we are not able to provide as physicians. Promoting patient needs in research, politics, and treatment approvals. And we have already discussed about the problem of the treatment approvals and the time needed in some countries. Paolo mentioned 3 years. Sometimes we are lucky we have 2 years, but for instance, in Italy, the approval and the reimbursement processes are quite long. In some cases, we were very lucky, and I have to thank the industry, because we were able to use chemoimmunotherapy in first line immediately after the presentation of the TOPAZ-1 data, the durvalumab data. For 2 years, patients in Italy received chemoimmuno paid by the pharma company, and in the end, after 2 years, the government decided for the reimbursement. But it's not always the case. In some cases, we have to wait for years. And I'm saying we, but I'm saying the patients, the whole community has to wait for a too long time before the reimbursement, before the approval. And of course, also it's important to provide good information, reliable information, and to be a link between physicians and patients. Next slide, please. And so this was too long, so the Italian version is on the next slide. But anyway, it's more or less more detailed, but more or less the same. So to me, it's important to create networks. Already mentioned also this for sharing experiences. Provide trustable information about the condition, about the cholangiocarcinoma, about the treatments, and about the adverse events associated with the treatments. And Helen showed the patient leaflets, the books that are really important for providing patients with information about the different treatments and potential adverse events or side effects. Research. I'll show at the end an example of this in pancreatic cancer, but it's very, very important to me. And also advocacy. Paolo already mentioned, and I will show the example of the reimbursement of NGS in Italy that was completely driven by APIC. And awareness, because we still need to improve the awareness about cholangiocarcinoma, because most of the people, but also in the healthcare system, most of the physicians do not know enough or do not know at all about cholangiocarcinoma. Next slide, that is the Italian version. Okay. And so, why? To me, patient associations are important, and how they can help patients and families. I mentioned they offer support in some way that healthcare providers may not have time to give, and this is important. Again, we need to work together. Provide reliable and patient-centered information, so information that could be helpful for the patients. And help patients make informed decisions. Sometimes we present a lot of things, and then in the end, maybe patients do need to discuss all the information with someone else to have the possibility to make their own decisions. And next slide, please. And these are the key points. To me, again, already mentioned, and I'm really happy. So the patient associations can provide the patients and the families with a list of referral centers in their countries, and in referral centers, a multidisciplinary team focused on cholangiocarcinoma, biliary cancer, or at least liver should be in place. And this is important also for the molecular profiling, because molecular profiling can be done, for instance, for lung cancer. And we know that the panel used for lung cancer is not, or should not be, the same used for cholangiocarcinoma, because we need to identify, in some cases, different alterations. And this is important to improve precision oncology, also in a rare disease that is not so rare now, like cholangio or biliary tract cancer. Another important point is to improve the access to drugs and testing, and to improve the access to clinical and translational trials. And already mentioned, being enrolled in a clinical trial is really important for the patients. There is the possibility to have access to new drugs that are not yet available in clinical practice. And for instance, one thing that I always try to explain, when patients are enrolled in a randomized trial, for us, randomized trials are needed, and also for the regulatory agencies. Patients do not like randomized trials, especially when they are randomized versus placebo or versus the standard of care, especially if the standard of care is chemo. What I always try to explain is, even if you are not in the new drug arm, you receive the standard of care maybe, but you have the possibility to undergo more testing, more consultations, to have the research nurses dedicated. So to me, at least, maybe I'm wrong, but to me, the level of assistance is superior when you are enrolled in a clinical trial compared to clinical practice. Maybe this is the reality of Italy, maybe in other countries is different. It's different, but for instance, for us, when the patient is enrolled in a clinical trial, there is a completely different path compared to the national health system. That this is the case, with the dedicated research nurses, expert in the disease, and so I think this is a good opportunity. Either a patient is randomized in a new drug arm, or in the clinical practice arm. And of course, we also have phase 1 and phase 2 trials where new drugs are tested, and so there is the possibility to receive new drugs in the trial. And another important point is the education about misleading information. You all know that surfing the internet can be good because you can find good information, or the patient associations or the referral centers, but sometimes you find misleading information, fake news, or even worse, physicians. I don't know if they are physicians, but offering treatments without any rationale, and in most of cases that should be paid. So even in countries like Italy, where all the drugs are provided for free by the national health system. So I think this is another important point. And coming to the conclusions, 2 examples of what has been done in Italy, and to me, very good examples. One, as Paolo mentioned, we had pemigatinib approved. That was the first targeted agent approved for cholangiocarcinoma in Italy, but the testing was not reimbursed by the government. So in theory, we were able to provide the drug for free, but we didn't know which patients could have benefited from the drug, this Italian typical thing. So thank you, Paolo, because they were able, also with the help of Insight at the time, but they were able to convince the government to provide funding for NGS. And then now there are issues related to the regional health system, because in Italy the national health system works on a regional basis. For instance, in Lombardy, where I work, and I'm lucky to work there, now the NGS is reimbursed for all the patients with advanced disease, and we don't have any issues in doing that, either on tissue or on liquid biopsy, but this is not the case in other regions in the same country. And so again, there can be disparities, inequalities in the same country. This is not acceptable. And the other example, you can go please to, okay, this was the example of pemigatinib, and then the another one. This is from pancreatic cancer, but it's key. I think that patient association can be helpful also in research. The PAC-221 or Cassandra trial is a perioperative phase 3 trial of chemotherapy in pancreatic cancer. This is a multi-center Italian trial, orally presented at ASCO and published this year in the Lancet. No industry involved, pure academic trial, completely funded by patient associations. I do understand that in pancreatic cancer there are more patient associations and more money, I do understand, but this was completely funded, and you can see the acknowledgements on the right, and I put in bigger character the 2 most important patient associations. This is something that is really, really important to me. Maybe in cholangio now we don't have the possibility to run a phase 3 trial, but maybe to support research in other way, to support maybe a smaller trial, this is important. I think this is, to me, at least for what I'm aware of, one of the few, or the only one, at least in Italy, of course, the only one that is example of a phase 3 trial completely funded by patient associations, so no industry involved, no biases in terms of selecting the population or the option. This is with chemotherapy, so no very expensive drug, but this is a practice-changing trial because in the end, the experimental chemotherapy regimen was demonstrated superior to one of the standard use. So again, this is important. And I think there is the last one. Yes. Coming back to the Lancet Regional Health Europe initiative, I think, and I do believe that collaboration between patient associations, physicians, is key. We can improve the knowledge, the awareness. For instance, the first of these papers was on mapping the landscape of biliary tract cancer in Europe, and we identified, again, disparities, challenges, controversies. The second one was on the treatment. Then we had the comment, the paper by the patient advocacy groups, and then the other one. And as mentioned, this was presented at EASL Liver Cancer Summit, so one of the biggest conference on liver cancer in Europe, on Cholangiocarcinoma Day. And this can improve the awareness and can improve the way, I think at least, we treat patients with cholangiocarcinoma or biliary tract cancer. And I think this was the only one. Thank you so much.